Hi, I speak the promoter polymorphism and interstitial launch abnormalities. Definition: what is a subclinical interstitial launch abnormalities are relatively common findings on imaging studies in smokers and elderly people. A single nucleotide polymorphism SNP-RES 35 70 59 50 in the promoter of the gen encoding MUC 5B and UC5B was shown to be associated with both familial interstitial pneumonia and sporadic idiopathic pulmonary fibrosis. This video.
First of all, I suggest that you watch this video in HD and in full screen by adjusting the settings on your player so you can appreciate the fine details of the images. Once again, our normal chest X-ray is in front of us, and compare it with the X-ray that is visible on your left hand side. Now if you have seen a few normal chest X-rays, you'll realize very quickly that there is definitely something wrong with the patient on your left hand side. The mediastinum is white in this area on this patient. There is a mass effect in aortopulmonary window, so the aortopulmonary window on this patient is this, which is normal, but there is a mass effect here, and there is a mass effect, there is a widening here in this part of mediastinum on the X-ray on the left hand side. So first thing that comes to mind after seeing the mediastinal widening in this area would be enlarged lymph nodes. You can see abnormal opacities in both lungs here as well, and there is an abnormal lucency here and in this area, and most probably in this area as well. You would agree that there is a reticulonodular pattern, and there are fibrotic changes in mid zones on both sides, and as the lung shrinks in volume as a result of fibrosis, it can produce what is known as traction bronchiectasis. So shrinking interstitium pulls bronchi to dilate them in a non-uniform. So this probably is a dilated bronchial branch. You can see thick walls on both sides, and this is the same thing, a dilated bronchial branch. An axial CT scan image from the same patient, a bit below from carina, and you can see calcified lymph nodes. You can see calcification here, and you can see calcification here. These are enlarged calcified lymph nodes. An HRCT image from the same patient, a cut taken just below the level of carina. So this is carina here, right main bronchus, left main bronchus, and you can see traction bronchiectasis here, here, and here as well. So the dilatation of the bronchial branches is visible clearly. So this is a bit small from here and a bit more dilated from here. You can see the thickened walls of the bronchial branches. Normal bronchial tree should taper towards the periphery, okay, which is not the case in this case. On this image, you can also see what are known as perilymphatic nodules visible on both lungs. These are nodules within interstitium which can be subpleural. They can also be present along the fissure or along the interlobular septae and or adjacent to bronchovascular bundle. But before I continue on this, I want to show you another image from a different patient. Okay, another image with perilymphatic nodules, and as I said, these are the nodules within interstitium. I guess it would be very difficult for a newbie to agree with me, but I just wanted to make a point, and the most convincing thing for me would be to show you this fissure, which is sort of beaded in shape, unlike this smooth and regular line. So these beaded shaped structures are the perilymphatic nodules, which as I said can be present which can be present along the fissure and within the interlobular septae as well as adjacent to bronchovascular bundles. So all the features mentioned so far, that is lung fibrosis, traction bronchiectasis, and the presence of perilymphatic nodules, are suggestive of interstitial lung disease. In this case, both the patients have been diagnosed with sarcoidosis. Please note that the first patient also has enlarged lymph nodes, which along with the presence of all the features mentioned before should make you think of sarcoidosis. Also note that the most common cause of perilymphatic nodules is sarcoidosis, although they can be present in other interstitial conditions.
The bathroom. A common promoter polymorphism is CD570 5950 in NUC5B. The hanging counting mousing 5B is associated with idiopathic pulmonary fibrosis. It is not known whether this polymorphism is associated with interstitial lung disease in the general population. The methods. We performed a blinded assessment of interstitial lung abnormalities detected in 26 Series 3 participants in the Framingham Heart Study by means of volumetric chest computed tomography, which evaluated the relationship between the abnormalities and the genotype. The results of the 26 Series 3 chest CT scan that were evaluated interstitial lung abnormalities were present in 177, the 7% participants with such abnormalities were more likely to have shortness of breath and chronic cough and reduced measures of total lung and diffusion as compared with such abnormalities. The conclusions. The NUCS5B promoter polymorphism was found to be associated with interstitial lung disease in the general population. Although this association was more apparent in older persons, it did not appear to be influenced by cigarette smoking. The experiment.
The MUC5B, the promoter polymorphisms, interstitial and lung abnormalities. What is the MUC5B? A common promoter in polymorphisms. This gene encoding mucin 5B is associated with idiopathic pulmonary fibrosis. It's not known whether this polymorphism is associated with interstitial lung disease in the general population.
We found that a variant in a gene called MUC5B, it's a gene that produces mucins or mucus in the lung, is strongly associated with the development of pulmonary fibrosis. And if you have this gene variant, you have between a 6 and a 20-fold increased risk of developing pulmonary fibrosis. Now, why is this important? It's important because this gene, MUC5B, that produces mucus in the lungs, was never known previously to be involved in the development of pulmonary fibrosis. I think the most important next step is to figure out how we can alter mucus production in the lung and whether that affects the progression of disease or the risk of developing disease. So we're going to focus on a variety of different treatments that we think may be important in terms of altering the course of disease. We're also going to use this variant to see whether we can predict who's going to develop disease, and we're going to use this variant to help us understand the basic biology of the disease, the basic pathogenesis of the disease.
The test.
The methods.
The methods.
We perform a blinded assessment of interstitial lung abnormalities detected in 2,633 participants in the Birmingham Heart Study by means of volumetric chest computer tomography. We evaluated the relationship between the abnormalities and the genotype of the RS locus. The results of all the patients' chest CT scans that were evaluated, interstitial lungs abnormalities were present in 177 or the 7% of the participants. These participants with such abnormalities were more likely to have shortness of breath and chronic cough. After adjustment of covariates for each copy of the minor RS allele, the odds of interstitial lungs abnormalities were 2.0 times greater, and the odds of definite CT evidence of pulmonary fibrosis were 6.3 times greater. As conclusions, the MUC5B promoter polymorphism was found to be associated with interstitial lung disease in the general population, although this association was more apparent in older persons. It didn't appear to be influenced by cigarette smoking.
The tense.